Hello, everyone. Today, we're going to tackle one of the most common and important presentations you'll see in orthopedics, the rotator cuff tear. This is a condition you will encounter again and again on your ward rounds, in your final exams, and most definitely in your OSCEs. So let's build a clear, systematic approach to it together. So why does this matter so much? Well, rotator cuff problems are the #1 reason patients over the age of 40 will present to you with shoulder pain. Getting this diagnosis right is absolutely critical. It's the difference between timely management and a good outcome versus a misdiagnosis that can lead to chronic disability and a tear that eventually becomes irreparable. The stakes are truly high, and it all starts with you at the bedside.
To make sure we cover this properly, here is our plan for today. We'll start by understanding the clinical challenge. Then, we will move step by step through patient assessment, synthesizing a case, confirming the diagnosis, planning management, and finally, we'll master how to present all of this perfectly in your OSCE.
All right, let's begin. The shoulder, as you know, is an incredibly complex joint. There are many other conditions that can present just like a rotator cuff tear. And this is precisely why a systematic approach isn't just helpful, it's absolutely essential to avoid falling into diagnostic traps.
Every good diagnosis in medicine is built upon a solid foundation. And that foundation always has been and always will be a meticulous history and a focused clinical examination.
You know, the diagnosis often starts to reveal itself before you've even laid a hand on the patient. You must listen. An age over 40, an occupation with overhead activity, these point towards a degenerative tear. Ask about the onset. Was it sudden, after a fall, or has it been creeping up gradually? The character of the pain gives us huge clues. Ask about pain on the side of the shoulder. And specifically, ask about night pain. It's a very suggestive feature. Then you must ask about functional weakness. Can they comb their hair? Can they reach up to a high shelf? And finally, always ask about their medical background. A history of diabetes or previous steroid injections is very, very relevant.
Now, we examine the patient. And the first step is simply to look. Stand behind your patient and inspect both shoulders. You're looking specifically for muscle wasting. A little hollowed-out appearance here in the supraspinatus and infraspinatus fossae suggests that the problem has been there for a while. And always, always compare it to the good side. Next, you palpate. Your fingers should systematically find the greater tuberosity, and tenderness localized right at this point is a key sign.
Next up is the range of motion, and here we look for a classic finding called the painful arc. You'll ask the patient to actively lift their arm out to the side. As they do this, you'll see the pain often starts around 60 degrees and then eases off past 120 degrees. This happens because the inflamed tendon is getting mechanically compressed under the acromion in that range. Now, a crucial point here, passive range of motion is often much better than the active range. This helps you differentiate it from something like a frozen shoulder. Now for the special tests. These help us to isolate the specific tendons. For the supraspinatus, we use the empty can test. For the external rotators, like infraspinatus, a positive hornblower sign is very telling. For the subscapularis, the lift-off test is key. You ask the patient to try and lift their hand off their lower back. And for a suspected massive tear, the drop arm test is a dramatic sign. The patient simply cannot lower their arms smoothly from 90 degrees. Now, this is a step that is often missed, and it's so important. A good clinician not only knows what a condition is, but also what it is not. You have to rule out the imposters. Could this be primary impingement? Neers and Hawkins-Kennedy tests will help you. Could the pain actually be coming from the AC joint? The crossbody adduction test will help you localize it. Is it referred pain from the neck? Never forget the neck. Perform Sperling's test. And as we mentioned, could it be a frozen shoulder? Check for a global restriction of both active and passive range of motion. Never skip these steps. All right, we've gathered our data from the history and examination. Now comes the most important part, synthesizing all of this information into a coherent diagnosis. Let's work through a classic clinical scenario. Here's a typical OSCE case. A 55-year-old female presents with a 6-month history of gradual shoulder pain. So let's synthesize the findings. From her history, we have night pain and functional weakness. On examination, we see the supraspinatus wasting. Her range of motion shows a classic painful arc. And our special tests? We have a positive empty can test and a positive drop arm test. Crucially, our rule-out tests for other conditions are negative.
When you put all of that together, our provisional diagnosis becomes very clear: a rotator cuff tear, specifically involving the supraspinatus.
So, we have our provisional diagnosis. The next logical steps are to confirm it with the right investigations and then to formulate a sound management plan for the patient.
When it comes to imaging, we have three main tools. An X-ray is our baseline. It won't show the tear itself, but it's essential to rule out things like arthritis or a bone spur. Ultrasound is an excellent tool. It's cost-effective, it's dynamic, and it's very good at picking up full-thickness tears. But the gold standard, what we call our surgical blueprint, is the MRI. It gives us exquisite detail on the tear size, how much the tendon has retracted, muscle atrophy, and fatty infiltration.
And this is precisely why the MRI is so crucial. Take a look at this Goutallier graphic. It shows what happens to the muscle over time after a chronic tear. You see, the muscle belly starts to atrophy and it gets replaced by fat. We call this fatty infiltration. High-grade fatty change, as you see in stage 3, is often irreversible. This is like the biological clock of the muscle. So an MRI doesn't just confirm the tear, it tells us if that tear is even fixable, which directly guides our surgical decisions.
Our management follows a very clear, stepwise pathway. And the guiding principle is this: we almost always start conservatively, especially for smaller, degenerative tears. This means rest, anti-inflammatories, and a structured physiotherapy program. We only escalate to considering surgery if a good trial of conservative management fails after 3 to 6 months, or of course in cases of a large acute tear in a young, active patient.
When surgery is indicated, we have several options. The most common is a minimally invasive arthroscopic repair. For very large or complex tears, an open repair might sometimes be necessary. And for massive, irreparable tears in older patients with significant dysfunction, we have an excellent salvage procedure called a reverse shoulder arthroplasty, which can restore their function remarkably well.
And now for the final piece of the puzzle, presenting your findings in the exam. This is all about being clear, structured, and confident in your delivery.
So, how do you present this in an exam? Here is a model presentation that should take you less than 90 seconds. This 55-year-old female presents with a 6-month history of gradual onset right shoulder pain, associated with night pain and weakness on overhead activities. Examination reveals supraspinatus wasting, a painful arc on abduction, a positive empty can test, and a positive drop arm test. My provisional diagnosis is a rotator cuff tear of the right shoulder, likely involving the supraspinatus. My management plan would be to first confirm the diagnosis with an MRI and then to initiate conservative management with physiotherapy. I would review her in 3 months, and if there is no improvement, I would consider surgical intervention, such as an arthroscopic repair. You see, it's structured, confident, and it demonstrates safe clinical thinking.
Let's summarize the key takeaways. First, the mistakes to avoid. Never, ever skip your differentiation tests. Don't jump straight to surgery in your management plan. And please, do not plan a surgical repair based on an ultrasound alone. And now for the pro tips to remember. Always start with conservative management. A positive lag sign is a very strong indicator of a full-thickness tear. And a crucial point, particularly for a patient population here in India, always screen for diabetes before giving a steroid injection, as it can significantly raise blood sugar levels.
We have now built a complete clinical playbook. But the key is not just to memorize it, but to internalize this thinking process. So the real question is, the next time you are on the wards and a patient presents with shoulder pain, how will you apply this systematic approach to arrive at the right diagnosis and the best plan for your patient?
And that completes our clinical guide to the rotator cuff tear. Make sure you practice this systematic approach. If you have any questions at all, please leave them in the comments below. And if you found this useful, please do like and subscribe for more clinical guides from Bedside Clinics.